Welcome to the EAU podcasts. In this episode, UROONCO Kidney Cancer Associate Editor Dr. Bertolo talks to Professor Autorino on the topic of the surgery in kidney cancer, the choice between multi-arms and single-port platforms.
This is Riccardo Bertolo from the European Association of Urology UROONCO platform. I have the pleasure of sharing some thoughts on the current multi-port versus single-port dilemma here at the AUA meeting in Las Vegas with Professor Riccardo Autorino. Professor Autorino is the Director of Surgical Innovation and Clinical Research at the Rush Department of Urology and among the most expert urologists here in the United States using the single-port platform. Good morning, Professor Autorino, and thank you for joining us today. We are here at the AUA Congress to discuss a topic that's gaining increasing attention, especially when talking about what is surgery for kidney cancer. The choice between multi-arm and single-port body platforms. I'd like to hear your expert opinion on some key aspects of this evolving debate.
Thank you, Riccardo, for the invitation. It's a pleasure to be here to discuss this important topic.
First question is single-port and multi-port platform each have unique strengths. From your plenary crossfire debate lecture, it was clear that this is not a one-size-fits-all scenario. Rather, the two platforms are complementary, and quoting you, the key is to pick the right tool for the right case. How do you decide which approach is best tailored to specific renal surgery?
Thank you again for this is an important question. And what I tried to do during the crossfire debate yesterday was really to make sure the audience will understand how important is case selection, especially for partial nephrectomy, which, as we know, is a surgery where bad things can happen, like intraop bleeding and other things. And so you want to also be safe when you do that procedure. So the case selection is very important, especially at the beginning of your experience with single port. When implementing this new technology, you have to be careful or select the best patients. And those are certainly patients where there is a low complexity mass, low renal score, and where the location is the mass is also favorable location. Lower pole of the kidney or in proximity the peripheral part of the kidney. Now, as you know, as everybody knows now, the major advantage of single port was to transition from transperitoneal to retroperitoneal surgery, which is a huge advantage, especially in those patients who had previous abdominal surgeries, where the transperitoneal approach can be really cumbersome. However, it's a different machine. The consult surgeon needs to adapt to this new machine, new way of how the technology works. And so that requires a learning curve. And so that's why case selection, again, is very important.
Thank you. My second question is, you concluded your lecture by saying anything can be done with SP doesn't always mean it should be done. Could you share some example where you feel single-port surgery clearly offers an advantage and others where multi-port remains the better choice?
Yes, absolutely. So this is also an important point. As I pointed out in my lecture yesterday, you still have to maintain multi-port practice because that comes very handy in situations where the single port doesn't really shine much. It's doable to do everything with single port. However, the value of single port is more when you have to work in narrow spaces. Having said that, that means also that, for example, in or procedures like radical cystectomy or radical nephrectomy for high volume tumors, certainly you can do that with single port, but probably you won't see that advantage for the patient as you see, as compared to multi-port. Of course, as you mature your experience with single port, talking about partial nephrectomy, you can certainly tackle more challenging masses. And one classic example is usually part of the discussion when they talk about lower anterior approach with single port. How about upper pole masses? Yes, so you can do those upper pole masses, but certainly the working angle is not ideal. And so probably in that scenario, unless you wanna really avoid the peritoneal cavity, then you probably should do that with multi-port. That's what I do. Or cases like challenging hilar renal masses, really. Those, I define them as borderline partial nephrectomy. Those who are really, you don't know if you're going to make a partial nephrectomy or radical, then those you probably should do that with multi-port.
Yeah, thank you. We will also see your kind of nomogram, your mental algorithm that you follow every single day for every single case to decide which is the best.
Yeah, I think each of the surgeons in the US who adopted single port made their own algorithm, and that can vary also again based with experience with cases that you've done. But certainly those are the main criteria: patient characteristics, previous surgeries, obesity, BMI, and two more renal characteristics: perirenal fat, location, size of the mass.
Thanks. And another question: while single pore surgery is often praised for its cosmetic and recovery benefits, do you see any trade-offs today in terms of surgical precision, instrument versatility, or the management of complex cases? We partially already talked about this.
Yeah, so I think cosmesis is not really the point here. Cosmesis becomes a point only probably if you look at patients who have some type of reconstructive procedure. The classic example is the young patient with pyeloplasty, maybe young female patient with pyeloplasty. In that case, certainly, I think if you have a single pore platform, you should do that operation with a single pore. It doesn't make sense to do multiple incision on that young patients where cosmesis is really important. However, the more important thing is, as you were mentioning, the recovery benefit, how faster the patient recover, how faster the patient can get out of the hospital, and how faster more importantly, they can get out of to their daily activities, which is very important to them. Now, in terms of surgical procedure, of course, and initial, of course, as you mature your experience at the beginning, of course, your surgery will take longer. Of course, you're not gonna be as precise as you will be with multiport. But then, as you mature your experience, you will see that also operative time will be shorter, and you will basically replicate what you can do with multiport. But certainly there is a price to pay at the beginning, which is a learning curve.
Do you perceive any kind of difference in suturing maybe and rhinorrhaphy, because the elbow is different with respect to the endoverse?
Maybe you know this because you worked on this and you published on this. So certainly the system, the dynamics of the instruments are different. So as a surgeon, you get used to this new setup. And as the suturing, yes, is different. So you have to get your mindset is used to multiple. So you need to build a new mindset that is used to this new type of technology. But at the end, after you are able to pass that learning curve, you can again your really brain is able to change and adapt to this new thing.
Yeah, thank you. And considering the learning curve associated with SP technology, particularly for complex renal procedures, how realistic do you think widespread adoption is at this point? As you rightly mentioned during your lecture, we were all trained with multiple platforms, so this is an issue.
Yes, absolutely, it's an issue, but has been an issue also when the robot was first introduced. So I think the technology, if the technology can bring a benefit, it will spread. Now the single port came at a really, the history of how it was introduced to the market is it needs to be kind of carefully analyzed, in the sense that it came during the time where pioneers of these, they were not really understanding exactly how to use the machine. They had this tool, but they didn't initially were working a lot with the transperitoneal approach, which was not bringing any benefit. Very classic example is the study Dr. Patel published comparing prostatectomy done transperitoneal, single port and multiple. You won't probably see any difference there. But then with time, with the discovery of new approaches I want to mention here Dr. Kivellaro's lower anterior approach with retroperitoneal kidney surgery. That has changed. So if there is a benefit, then the surgeons will adopt this technology. Now, also one thing to mention, single port came also survived the COVID period, right? With everything stopped. So for about 2 years, nothing really was being implemented because it was COVID. So now I think it's the time, and we've seen this in last year, especially in the United States here, with a large increase of the installation of a single port robotic platform. I proctored many surgeons in the US. They are starting in different settings, from the academic centers to the small private hospital. It's important, however, to point out that the surgeon who starts this needs to have a background, an experience, a background in robotic surgery. They need to know what they are doing, and because again there is a learning curve and that can come with complication at the beginning. So you have to be careful, and you have to have that background that can support you to go to the learning curve.
Yeah. And last question, from a cost benefit perspective, especially for smaller non-academic center you were mentioning about, do you view investment in single port platform as a strategic move today, or move of a selective case-by-case decision?
Yeah, I would say if you are a center, as you know, in the United States, a lot of these academic centers, they have multiple platforms. They will have 4, 5, 6 robots. So if one of them is single port, I think is a good thing to have, because you can then, again, use on a case by case the best tool for that patient. Different things if you work in a community, rural hospital, where you might only have to decide, you need to decide, which one, if you have to buy a single port, multi-port. And it might be a little bit of a stretch to say you have to buy only a single port. It might happen in the future. It might be too premature now. But I think as a large academic center where you maybe have 3 MRI machine, 3 CT scan machine, then you probably you're going to have also 2, 3 robots. One of them, I think, should be single port, so because you can then benefit your patients with that. And also when you talk about costs, and there are in this sense there are not many. The evidence on this is not very, and single port is not many papers out there. Some of them tells us that you can compensate the higher cost of the instruments of the single port with the shorter hospitalization. That could be true, but also you have to think also to the societal benefit. So not only the cost itself of the procedure, but also how quick the patient can go back to the daily life. And I think cost should not be the primary driver of what we do. It should be always the clinical outcome. Patient.
Yeah. So thanks a lot, Professor Autorino. It's been great hearing your expertise on such a hot topic at the AUA.
Thank you for listening to this episode of EAU Podcast. To keep up to date with kidney cancer developments, visit our educational platform, UROONCO Kidney Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.